Dr. Shapiro is a professor of neurological sciences at the Larner College of Medicine at the University of Vermont, where he is director of the Division of Headache Medicine and the UCNS Headache Fellowship. He holds a master's from the University of Oxford, a PhD from the University of Pennsylvania, and an MD from Columbia University. He completed a residency in neurology at Johns Hopkins Hospital. He's the founding president of the Alliance for Headache Disorders Advocacy, the past president of the Headache Cooperative of New England, and currently serves on the board of the American Headache Society. For full disclosure, he's also my headache specialist. All right, and one more housekeeping item. As you have questions for our presenters today, please type them into the chat box and we will address them at the end of each session. We're ready for Dr. Shapiro.
Okay. Can you all hear me? Yes? Yes?
Yes.
Okay, so thanks very much, Miles for Migraine and Katie, for inviting me to participate in this. I think it's a terrific event, and Miles for Migraine is a fantastic organization. It's really nice to see a bunch of people who I've seen at Headache on the Hill in the past, and a few, including Katie, who are patients of mine as well. I hope this is of value to you all. Another disclosure, I actually am a consultant for Eli Lilly for their clinical studies. I'm not an investigator, but I've been involved in consulting for them. So I'm going to talk today about advocacy and advocacy with respect to Headache on the Hill, which some of you are aware of, and momentarily you'll all be aware of it. So the first issue is to understand where does advocacy engage, and we need to understand how it is that people experience disease and where are the burdens that exist for diseases. And migraine is a very important disease in terms of its burden. So what people experience is are the symptoms of a disease, and what doctors elicit and can detect on examination or through studies are the signs of a disease. But how the disease impacts your functionality is related to disability or impairments. But beyond that, there's this barrier between your experience of your disease and how your disease is appreciated by society overall, and actually by yourself. And this can be broken down into several different areas. The first is your interpersonal connections, that is your family, friends, and then people who are a little bit more distant from you in terms of your social interactions, teachers, clergy, healthcare providers in particular, and coworkers. And that at an even larger level, there are institutions in the country, both governmental institutions in terms of Social Security, disability insurance, the health insurers, workers' compensation, the law, media, medical research, and then finally, the stigma can impact one's own self-esteem and one's own sense of one's worth, and that can lead to a significant concealment of whether or not you actually have the disease if you don't have physical signs of the disease. And this is a huge aspect of engaging to overcome the barriers and burdens that migraine imposes. So what we've been involved in specifically with Headache on the Hill, really since 2007, which was the first event, was all the stuff on the right side of this figure, that is structural stigma, the institutional changes, the barriers, the discriminatory policies and practices, which are really embedded in our functions and institutions that we all share and which develop policies. And so we've been engaged in virtually every realm that we can identify where there are discriminatory barriers. We've been trying to call them out and trying to correct and reverse them. And as you'll see, there are many, and virtually everywhere you look, you can find them, and they're profound, and they have a huge impact for people who have migraine. So our organization is called the Alliance for Headache Disorders Advocacy, and our mission really is to advocate on behalf of patients who have headache disorders such as migraine, and for the aspect of medicine, organized medicine called headache medicine, which takes care of and tries to respond to these burdens that people with headache disorders experience. As I say, our major annual event is Headache on the Hill. I'm going to speak about that in greater detail momentarily. AHDA was incorporated in 2008 and attained nonprofit status in 2013. It's comprised of member organizations and funded by those organizations and private donors. It receives no corporate sponsorship or funding, and it provides no money towards political campaigns. So it's really issues-oriented advocacy, and we try to steer clear as much as possible from the corporate donorship. So these are our current 13 nonprofit member organizations. It runs the spectrum of organizations engaged in this area or field, both on behalf of patients in particular and also professional organizations. And this lineup has been pretty stable over the last 13 years or so. So our first Headache on the Hill was in 2007. It was a fairly modest number of people, but we had a pretty big impact. We visited 136 congressional offices, and since there are a total of 538 of them, we actually had a pretty big impact right from the start. Almost everybody in this photograph is a doctor, and that was not the intent of the organization to be just doctors, but it was easiest to organize physicians initially. We only had one or two patient advocates who were participating the first year. The most recent Headache on the Hill in February of this year, we had a huge increase in the number of advocates, and I think it's around 70 to 75% of the people who are participating are patient advocates. And we think that the most effective way to approach congressional offices and to try to move policy is to have a partnership between patient testimony for what they're experiencing and what the issue is with the context which a clinician, their doctor, can provide in terms of how to apply this in terms of changes in policy. So we do this every year. We think that, and actually it's well proven in terms of other organizations who are trying to move federal policy, that this is an essential process. This is a necessary piece to try to change the course of these structural barriers in federal policy. So the first thing the first real impetus for Headache on the Hill was a recognition here. Now this is a little bit of a complex slide, but bear with me. So this is a what's called a scatter plot, and every dot on here represents a different disease. There are about 77 of them on here. And the distance that the dot is to the right is how much burden that disease has been calculated to have, which includes how many people have it, how much mortality, that is, how much it shortens lives, and how much disability it may accrue for people who have the disease. And on the vertical axis is the amount of NIH funding. So the dot that's in the furthest to the right and the top is cancer, so it impacts a whole lot, and there's a lot of money. And any disease which is further to the right has a higher impact. And what you see is that migraine, among the most burdensome diseases, is way, way far the least funded. And if you draw a vertical line through the migraine dot, you come up with diseases which have approximately the same burden by this measurement tool called the Daily. And you can see that the underfunding of migraine is at least tenfold, if not greater, relative to burden. Now, there are many other reasons why diseases would be appropriate to be funded irrespective of the burden. So obviously, coronavirus research a few years ago was money very well spent, even if it was a relatively small number of people who were affected, because it's now becoming clear how useful and important that is. So it's not just burden that we look at, but burden is clearly an important factor, and it's recognized by the National Institute of Health. So this is a figure that actually was taken from the NIH website. So we've been working really for the last 13 years very aggressively to try to move migraine's number upwards. And we've made some progress, but not enough. So initially, as I said, this was an impetus for Headache on the Hill. And there are various ways you can move Congress to try to support your initiative or cause. And one of them is to have a specific statement made in the committee report, which comes out of the Appropriations committees, both on the House and the Senate side, in support of how the agencies which those appropriations fund will use the money. And we've had actually 15 successful times which we've had the Appropriations Committee deliver messages to NIH saying, look, you got to pay attention to this. NIH has not been very responsive to this, but nonetheless, we keep trying. In 2016, we were able to participate in writing a bill which became law, which authorized NIH to increase pain research in response to the opioids crisis. And this would include headache disorders research. The following year, we again participated in writing a bill which would then provide the money under that authorization to increase funding. And before that had a chance to become law, Congress actually went ahead and appropriated the funds that we were asking for at a smaller level, but still a substantial amount. That is $500 million extra every year for for pain research and opioids research, called the Helping End Addiction Long-Term Initiative, or the HEAL Initiative. So far, the HEAL Initiative has not yet appreciably increased migraine and headache disorders research. We still have lots of engagement to do. And we asked for more appropriations report language towards this end. And this was a letter that we were able to, through Headache on the Hill, we were able to persuade 22 members of the House to send to the Appropriations Committee to support adding this language to the Appropriations Bill. And notably, to give you an idea about how important Headache on the Hill is to getting this sort of thing done, 20 of the 22 signatures here are individuals whose offices or they themselves were visited during Headache on the Hill. So had we not gone, it's highly unlikely that we would have had this letter, and it's highly unlikely that the report language we're requesting would have been included. So Headache on the Hill engagement to actually show up and be there and talk to these members of Congress is very, very powerful. And it's really we think the most effective way to advance these issues really in terms of changing public policy. So these are the 4 report language statements. You're definitely not gonna have time to read this. I'm gonna move on, but it's just giving you an idea that much of the information in here is repeated. And the idea is you tell them what you want, and then you tell them what you want, and then you tell them what you want, and you keep doing it. And sooner or later, hopefully they'll listen and be persuaded. This is not the only way we work on this, but it's one of them. So the other way we did, after we were able to obtain this report language, we sent a letter to the director of the Neurology Institute, which really has jurisdiction over research for headache disorders. And we went and met with him in December, collectively, really basically the leadership of all the major organizations related to this. And we met with all the leadership in this at NIH with respect to this. We haven't yet changed their minds, but we'll keep working on it. And this is really, the time horizon for this really is quite distant. You really need to be very, very patient, but eventually persistence really is the effective way to move with this. We've had just to give you an idea, several other initiatives and agencies we've involved with. So we were able to persuade the FDA to agree that migraine is a, quote, serious condition. So I think everybody on this call recognizes that migraine is a serious condition, but serious condition status is actually a regulatory designation. And it's only a disease which has serious condition status, which can be qualified to have expedited review of new drugs through the FDA. So this is really important in terms of trying to accelerate the availability of new medications. The Center for Medicare and Medicaid Services, they are Medicaid and Medicare. That's a couple of the key things that they regulate. And inexplicably and actually cruelly, I believe, they have denied Medicare beneficiaries who have cluster headache oxygen therapy, which is really the principal high effectiveness, inexpensive and safe therapy for this excruciating condition. And so we've been engaged with them for about 10 years in concert with other organizations. And we wrote this letter a year and a half ago to appeal to them based upon new evidence about why they should reverse their policy. They've yet to do this. And I can talk much more about this, but I'll move on. Social Security Administration, this is another area where there's really deeply discriminatory policy against people who have migraine and other headache disorders. And if you are disabled, you can no longer work on the job, and it's due to migraine, which can happen because migraine can progress over time. And we know that migraine is the second leading cause of US disability across all causes. It's about 5% of all calculated disability is due to migraine. You may no longer be capable of effectively pursuing your job. If you've worked long enough and you've paid enough into, through withholdings, you paid enough essentially premiums into the federal insurance program, you can apply for benefits under that, but you have to qualify. You have to show that you actually have a disabling condition. And there's a process that Social Security has called sequential evaluation to decide who actually is disabled by their disease. And it's a very formulaic process. And at step 2, you have to prove that you have a severe impairment. And the evidence that you can provide can only be signs or symptoms, things that people can detect on examination or provide in laboratory studies. And migraine doesn't have those. Migraine has symptoms. So right off the bat, there's this very difficult barrier that people with migraine have to be able to qualify as having a medically determinable impairment. And then at the next step, at step 3, you have to compare your impairment to a model description or listing of the impairments that arise from your disease. And probably a no surprise to anybody on the call, there's no listing for migraine or other headache disorders. So you have no way to compare it effectively. They require you to compare it to epilepsy, which is, you know, an apples to Buick's kind of comparison. And this is deeply unfair, but it's also illegal because there is a regulation which states that the Social Security Administration has to have listings for the most common impairments, and migraine is the second leading cause of disability, as I mentioned. There are a couple of further steps here, but by the time you get there, it's very, very hard to qualify. So as a consequence, if you look at people with migraine who are applying, it's about 1/18. There are about 18 times more people who have relative disability in the population than who actually go ahead and file claims for Social Security. Their lawyers say, look, don't bother doing it. You're not going to get it. So people don't apply. And of the people who do apply, they're about half the likelihood of actually getting it initially qualified. So these discriminatory policies have really deep effects, which are barriers to people receiving their legitimate benefits. So we've gotten, last year we were able to persuade their Appropriations Committee to add report language to try to correct some of these issues. And then we partnered with the National Organization of Social Security Claims Representatives. So NOSCR is the organization which represents attorneys, which represent claimants. And we kind of cajoled Social Security to finally issue what's called a Social Security ruling, which didn't change those policies I mentioned, but it provides the first guidance ever for how people with migraine and headache disorders should navigate towards achieving Social Security disability based upon the rules that exist. So we're still working on changing these policies that are discriminatory, but we've made some progress so far. So one other example, another example that I think helps illustrate how we work on this is with respect to identifying a problem and trying to figure out how to correct it. So in the VA system, this was about 5 years ago, we identified that there were over 100,000 veterans of the Iraq and Afghan conflicts who had post-traumatic chronic headaches, but there were only 3 doctors in the system which had qualifications to take care of this. This was obviously a pretty awful mismatch. So we borrowed from some centers of excellence which are in the VA system for epilepsy, for multiple sclerosis, for Parkinson's, and we thought it was appropriate there would be headache disorders centers as well. So we needed to get money or appropriations for this. So the first step was at Headache on the Hill in 2005. We asked members of the Senate to send a letter to the Secretary of the VA to ask what they're doing about this. And we were able to get 14 senators to sign this letter. And subsequently, a couple of years later, we're actually able to get the appropriations. And now there are 7 regional headache disorder centers with an appropriation of $10 million a year to help pay for this. We're asking for more money this year, and we'll see what we get. what we worked on in 2020 was another really deep problem, which is that there are just not enough doctors who are adequately and appropriately fully trained to take care of headache disorders. And the gap is really a deep one. So there really ought to be about 8 specialist doctors for every 100,000 Americans with migraine. And for most states, more than half states, it's less than 1 on average. Believe it or not, Vermont is the best staffed in the country. It's kind of an anomaly. It's kind of hard to believe. But even here in Vermont, we have a big backlog of patients in terms of being able to help care for the number of people who have this need. So there was an opportunity this year to try to work on this problem in particular. So there was a bill that came forward in both the House and the Senate called the Opioid Workforce Act. And this would increase the number of funding slots for doctors to be trained in addiction medicine, addiction psychiatry, and pain medicine. And we wanted to amend the bill to include headache medicine fellowships. And we asked like crazy, and we worked pretty hard, but we're not able to find a sponsor for this bill amendment. So for now, this has been put on hold. We're going to come back to it. It's really a critical issue. But this is the sort of thing you move on it, and then you keep coming back. And the persistence, eventually you find that you're successful. So in summary, here are some of the areas that we've been working on. Research at NIH, we were able to help really support these HEAL initiative appropriations. We've gotten tens of millions of dollars. Thank you to, in particular, to Senator Leahy, who has been instrumental in facilitating this through the Department of Defense for research on post-traumatic headache and chronic migraine. We were able to persuade FDA that migraine is a serious condition, that CMS, we're still working on oxygen for cluster headache. We've made some reforms for Social Security Administration evaluation, but there's still much work to be done. Veterans Administration, Headache Centers of Excellence. We really are very grateful to Senator Brian Schatz of Hawaii in this regard, and we're going to continue to work on these academic medical center issues with more headache doctors. So if you can, come join us. The next one is February 8th and 9th, and that's it. Thank you very much. And I think we have a couple of minutes for questions. I don't know. I think so, yes.
Yes, thank you so much, Bob. There's one comment here from somebody who said that they are on SSDI, but they have other medical issues, migraine being one of them, and they went through being denied SSDI once, but eventually looks like started being covered in 2007. That's actually not uncommon. We've found that many people who do get Social Security disability insurance for migraine end up getting it through going through the appeals process and having other comorbidities that actually help with the process of getting the disability. When you go in with just migraine, it becomes extremely difficult. So your situation is not rare. There's a question here. Somebody was enrolled in the American Registry for Migraine Research and just received word that it's ending data collection due to a lack of funding. Dr. Shapiro, do you have any thoughts on the impact this will have on migraine research? As a patient, it was nice to feel involved in the research.
Yes, this is very unfortunate that this registry, the acronym is ARMOR, there's actually an international portion of it called ERMR, really has been unable to secure adequate funding. The funding that had been provided to really get it launched was largely through industry sponsors, not with the expectation that this was going to further or foster their own drug development, but rather that this was to provide an ongoing process to help understand migraine and other headache disorders. But it's been very difficult to find other sources of funds. The NIH was not interested in supporting it. There's a long discussion about why that's true. It was not that I think they were singling out migraine, but rather they are not interested in supporting disease-specific registries because they have their own enormous registry called the All of Us Registry, which they're enrolling 1 million people. So as is the problem in this field overall, finding appropriate support for research commensurate with the burden of this disease, it's going to be with us for quite some time. And unfortunately, the registry was unable to secure that funding. Whether it will in the future be able to find that funding, I can't say, but given how challenging it is to get funding at all, I'll be a bit surprised whether or not it's possible to do it. And I'm very sorry for that. Thank you for participating. It's really only through the generosity of patients who understand that understanding their personal problem is what's going to move things along, so we understand everybody's problems with respect to these diseases. So thank you for your participation.
Great. That looks like one more question here. When you advocate at Headache on the Hill, do you find a certain percentage of legislators actually suffer from migraine or are closely impacted by migraine?
Yeah, I know a huge number of members of Congress who actually have migraine, and virtually every office you visit, it's absolutely the rule, not the exception. Every office, somebody who you're speaking to says, "Oh yeah, you know, my sister does, or my best friend does, or my spouse does, or somebody in my family." Migraine is so prevalent, and it's really such a problem for the people who experience it that this resonates. And it's never an advantage to have a problem that is so big that everybody is aware of it, but it's actually a weird advocacy advantage that when we talk about this sort of thing, it's something that people really get. And they usually are certainly less so now than they were 10 years ago. When we go into offices, they would say, boy, this is the first time anybody has really ever asked us or talked with us about this issue. But yeah, I understand what you're talking about. This is really a problem for somebody I know and care about.
Great. All right, we're going to